Welcome to this focused deep dive on pressure sores,
Good to be here.
especially for those preparing for board exams like the FRCS plastic surgery. We're really aiming to cut straight to the essential information today.
Absolute. They're common, aren't they?
Yeah.
Across different settings.
Exactly. General acute, long-term care, home care. It's a significant issue.
And certain groups are particularly high risk. Elderly with hip fractures, quadriplegic patients.
Right, and those needing chronic care. So our mission today, if you will, is to distill the crucial points for effective revision.
Sounds good. Where should we start?
Let's begin with the basics, the etiologic factors, what actually causes these sores.
Okay. We usually split them into extrinsic and intrinsic factors, things from the outside and things specific to the patient.
Makes sense. Let's cover extrinsic first.
Right. So first up is shear. This is like a parallel stress, skin layers sliding over deeper tissues.
And that affects the blood supply.
Precisely. It particularly hits the small muscle perforator vessels, leading to potentially superficial necrosis.
Okay, shear. What else externally?
Pressure, straight up perpendicular force. This squashes the tissue.
Blocking vessels deeper down.
Exactly. Causes deep necrosis. There's data suggesting even a couple of hours of significant pressure can cause irreversible damage.
Wow, okay, pressure and friction.
Yeah, friction's more superficial. Like rubbing during patient transfers, it wears away the outermost skin layer, makes it lose water faster.
So more fragile skin.
Definitely. And the last big external one is moisture. Think incontinence. It leads to maceration, skin breakdown, makes it much weaker.
Got it. Shear, pressure, friction, moisture. Those are the external culprits. What about intrinsic factors within the patient?
Well, anything reducing blood flow is a problem.
Mm-hmm.
Ischemia, sepsis, they decrease tissue perfusion.
Logically.
Then there's decreased autonomic control. This can cause issues like excess sweating, muscle spasms, incontinence,
Yeah.
all contributing.
Okay.
Infection itself, of course, makes things worse. Common bacteria like Staph aureus, strep species, E. coli, Pseudomonas, they're the usual suspects.
All right.
Increased age is a big one. Skin gets drier, weaker, more easily damaged.
More friable.
Exactly. Sensory loss is crucial too. If you can't feel discomfort, you don't shift position.
Leading to prolonged pressure.
Vascular disease, think diabetes, PVD, smoking all impair circulation.
Sure.
Anemia affects healing and can also lead to fatigue, so less movement. Malnutrition, well, that obviously impacts healing capacity.
Though vitamin supplements only help if there's a real deficiency, right?
Yeah, that's a key point. Only if they're actually deficient. And finally, an altered level of consciousness means those protective reflexes might be gone.
That's a lot of factors to consider. So when faced with a patient, how do we actually quantify their risk?
The Braden scale, that's the tool used most often.
Ah, yes, the Braden scale. What does it measure specifically?
It looks at 6 areas. Sensory perception, can they feel pain or discomfort? Skin moisture, activity level. Mobility, can they change position on their own?
Okay.
And then friction and shear exposure. And finally, nutritional status.
You get a score.
Yeah, from 6, which is very high risk, up to 23, low risk. Lower score means higher risk.
Are some factors more predictive than others?
Research suggests sensory perception, mobility, moisture, and friction shear tend to be the most predictive subscales.
And there are thresholds for concern.
Yes, though they can vary a bit by setting. Like in tertiary care, a score around 16 might be the cutoff, maybe a bit higher in veterans hospitals or nursing facilities.
Good to know those benchmarks. Now, if a sore does develop, we need to describe it accurately. Let's talk classification, the NPUAP stages.
Right. Stage 1. The skin's intact, but there's an area of redness that doesn't turn white when you press it. Non-blanchable erythema.
And that can show up quickly.
Within about 30 minutes, yeah. Usually resolves in an hour. Can be harder to spot in darker skin tones, mind you.
Okay, stage 1. What's stage 2?
Stage 2 is partial thickness skin loss. Looks like a blister, maybe an abrasion, or a shallow open ulcer. The dermis is involved.
Right, so the skin is broken.
Yes. This might happen after a few hours of pressure.
Then stage 3.
Now we're into full thickness tissue loss. It goes down to the subcutaneous fat, but not through the underlying fascia.
Okay, fat may be visible, but not muscle or bone yet.
Correct. And you might see undermining where the tissue loss extends under the edge of the wound or tunneling.
Got it. Stage 4.
Stage 4 is also full thickness loss, but it's deeper. You've got exposure of muscle, bone, tendon, ligament, potentially joint capsule. Much more serious.
Definitely. Are there other categories?
Yes, 2 more. Unstageable. This is full thickness loss, but the base is covered by slough that's yellowish dead tissue, or eschar,
Yeah.
which is black or brown necrotic tissue.
So you can't see how deep it goes.
Exactly. Until it's cleaned up, you can't stage it properly. Though, important note, stable, dry eschar on the heels often shouldn't be removed.
Okay, leave stable heel eschar alone.
Generally, yes.
Yeah.
Once debrided, these become either stage 3 or 4. And the last one is suspected deep tissue injury, or SDTI.
What does that look like?
It looks like a purple or maroon area of intact skin, or maybe a blood-filled blister. It suggests damage to the underlying soft tissues from pressure or shear.
But the skin's still closed.
Initially, yes. It needs time to declare itself, to evolve, before you can properly stage it. Might reveal a depot ulcer later.
Understanding those stages is fundamental. So let's shift to prevention. What are the core strategies?
Prevention is huge. Proper skincare is key, keeping it clean and dry, managing moisture.
Especially incontinence.
Absolutely. Careful techniques during patient transfers to minimize friction and shear.
Right.
Managing spasticity if it's an issue. Sometimes medications like diazepam or baclofen can help. But the big one is pressure dispersion.
How do we achieve that?
Padding bony prominences. Encouraging regular repositioning, that's crucial. Kosiak's principle suggests turning supine patients every 2 hours. For seated patients, lifting off for just 10 seconds every 10 minutes helps.
Small shifts, big impact, and support surfaces.
Yes, various options there. Static foam pads need decent thickness. Alternating aerosol mattresses can be good.
Those inflate and deflate different cells.
Right. Low air loss mattresses help keep skin dry and maintain low pressure. And then air fluidized beds with ceramic beads and warm air, very low pressure, great for moisture control.
Is one type definitively better?
Well, reviews suggest the more advanced surfaces, like low air loss or air fluidized, are generally superior to standard foam for high-risk patients.
Other prevention tips.
Keep the head of the bed elevation low, ideally under 45 degrees, to reduce sacral pressure. Address incontinence actively. Ensure good nutrition. And optimize any underlying medical conditions.
It's really a multi-pronged approach. Now, if a sore is already present, what's involved in the patient evaluation?
You start with a thorough history and physical, obviously, trying to pinpoint all those contributing extrinsic and intrinsic factors we discussed.
Right.
Pre-treatment labs are important. CBC, check for anemia, infection, glucose or HbA1c for diabetes control, inflammatory markers like ESR, CRP, nutritional markers like albumin or prealbumin.
Do those labs always tell the whole story?
Not necessarily. If things like anemia or low protein normalize after surgery, it suggests they were symptoms of the chronic wound state, not the primary cause. But they still need managing pre-op.
What about imaging? If you suspect bone involvement.
MRI is very sensitive and specific for looking at the extent of osteomyelitis, bone infection.
So MRI is key for suspected osteo.
Definitely. The main goal before any reconstruction is to identify and optimize absolutely everything intrinsic, extrinsic factors and understand the full extent of the wound, including any bone issue.
Critical for planning. Let's talk initial medical management then. What are the first steps?
Number 1, relieve the pressure. Repositioning, getting the right support surface. That's non-negotiable.
Absolutely.
Then control infection if it's present. Continue managing those extrinsic factors, moisture, friction. Debridement is usually needed.
Removing the dead tissue.
Yes. Can be done surgically at the bedside or in theater or sometimes with topical enzymatic agents. Dressings are crucial too.
What kind of dressings?
Depends on the wound. Things like hydrocolloids, simple wet-to-dry saline dressings, maybe dilute Dawkins solution very cautiously if you suspect Pseudomonas. Silver sulfadiazine is used sometimes, hydrogels, absorbent foams, lots of options.
Tailored to the wound. And confirming osteomyelitis.
Bone biopsy is the gold standard, the benchmark. But MRI, CT, even plain X-rays can provide evidence.
What about negative pressure wound therapy? VAC dressings.
Yes, NPWT. It can be really effective for stage 3 and some stage 4 ulcers. Helps repair the wound bed, can potentially speed up healing, and act as a bridge to surgery.
But it needs careful management.
Absolutely. Vigilant management, regular checks by the physician, at least every couple of weeks. It's an adjunct, not a standalone cure.
Okay, so when does surgery become the main consideration?
Generally, stage 1 and 2 ulcers don't need surgery. They should heal with good local care and pressure relief. Stage 3 and 4, however, often do require surgical closure, usually with flaps.
And what dictates the surgical approach?
Patient factors are key. Is the patient ambulatory? That affects flap choice significantly. We aim for large flaps, trying to keep suture lines away from direct pressure zones.
And preserving future options.
Critical. Avoid violating adjacent flap territories if possible. Think about potential future needs.
Single stage versus multiple stages.
There's evidence suggesting single-stage reconstruction could be just as successful as staged procedures, provided you do a thorough job initially.
What are the core goals of that surgery?
Okay, the goals are thorough debridement of all devitalized tissue, complete excision of any pseudobursa, that's the reactive sac that forms over bony points, ostectomy removing infected or prominent bone down to healthy bleeding bone,
Aggressive debridement is key.
essential. Then excellent hemostasis, stop the bleeding. Obliterate any dead space, usually with well-vascularized tissue like muscle, select the right flap, one that doesn't burn bridges, get a tension-free closure, and ensure durable pressure offloading post-op.
Sounds comprehensive. Any particular surgical tips?
Injecting a wetting solution saline, maybe with some local anesthetic and epinephrine, can help reduce blood loss and make dissection easier, sort of hydrodissects the plane.
Okay.
And using something like methylene blue dye can help visualize and ensure complete removal of a pseudobursa if one is present.
Useful tricks. What about raising the flaps?
Sharp dissection, often with scissors for fasciocutaneous flaps, helps preserve the blood supply. And be cautious not to over-undermine rotation flaps, as that can compromise their vascularity at the pivot point.
Good points. Let's run through common reconstructive options by site. Say, for the sacrum.
Sacral sores,
Yeah.
well, you got lumbosacral flaps, sometimes needing a back graft. Gluteal flaps are very common, either fasciocutaneous or myocutaneous rotation flaps.
Depending on ambulatory status.
Exactly. You might use just a segment of the gluteus muscle or the whole thing if the patient isn't walking.
Yeah.
Sometimes just a muscle flap to fill dead space under a skin graft. Gluteal VY advancement flaps, often myocutaneous, are another workhorse. They can sometimes be re-advanced if needed later.
Okay, lots of gluteal options. What about ischial sores? Over the sitting bones?
Similar players often. Gluteal flaps, again rotation or advancement. Posterior hamstring myocutaneous VY advancement is a classic. Posterior thigh, fasciocutaneous flaps. Even a tensor fascia lata or TFL flap can sometimes reach.
And trochanteric ulcers. Over the hip bone.
The TFL flap is probably the most common here, sometimes combined with part of the vastus lateralis muscle underneath.
Okay.
In complex cases, especially with hip joint involvement or severe osteomyelitis, a girdle stone procedure might be needed.
Which involves removing the femoral head and neck.
Yes, and often using the vastus lateralis muscle to fill the resulting dead space.
What if there are multiple ulcers or really extensive disease?
You try to tackle them in a single stage if feasible. But sometimes, really extensive bone involvement might necessitate radical procedures like hip disarticulation, hemipelvectomy, or even hemicorporectomy in extreme rare cases. Total or subtotal thigh flaps can also be used for massive defects.
Those are major undertakings. After the surgery, what's the focus of post-operative management?
Pressure relief is paramount. Usually on a specialized bed, like an air fluidized or low air loss bed, for at least 3 to 6 weeks. No pressure on the reconstruction.
Strict offloading.
Absolutely. Culture-directed antibiotics, often guided by an infectious disease consult. Continue antispasmodics if needed. Careful bowel management constipation can cause straining and pressure.
Good point.
Optimize nutrition continuously. Encourage active or passive range of motion for the uninvolved limbs to prevent stiffness and clots.
And eventually getting them sitting again?
Yes, but very carefully. Seat mapping is often done first using a pressure-sensing mat to identify high-pressure areas on their cushion. Then a gradual, supervised sitting protocol is introduced. And ongoing education is vital.
Education for patient and caregivers.
Yes, on pressure relief techniques, skin inspection, signs of problems, it's crucial for long-term success.
Despite all this, complications can happen. What are the common ones?
Hematoma, bleeding under the flap. Infection. Wound dehiscence, the wound opening up.
And recurrence.
Unfortunately, recurrence rates can be quite high, ranging widely in the literature, sometimes up to, well, quite significant percentages depending on the study and follow-up.
Are certain flap types better than others regarding complications or recurrence?
There have been meta-analyses. Generally, myocutaneous flaps might have slightly higher initial complication rates, but potentially lower recurrence. Fasciocutaneous flaps might have fewer early complications, but perhaps slightly higher recurrence. Perforator flaps show promise with low recurrence, but still have their own complication profile. It's complex. No single flap is perfect for everything.
It sounds like careful patient selection and meticulous technique are key, regardless of flap type.
Absolutely.
Okay, let's try to summarize the absolute key points for revision. What are the main take-homes?
First, thorough evaluation is essential. Surgery is really a later step. Address all the underlying etiologic factors first. A multidisciplinary team approach is crucial. Surgeons, nurses, physios, dietitians, occupational therapists.
Whole team effort.
Remember, vitamin supplementation only helps if there's a proven deficiency. Know the high-risk groups: elderly, hip fractures, quadriplegics, chronically ill.
Got it.
NPWT is an adjunct, a tool, not a magic bullet. Stage 1 and 2 are typically non-surgical. Stage 3 and 4 often need flaps.
Flap choice.
Consider ambulatory status. Segmental muscle flaps or fasciocutaneous flaps might be better if the patient walks. Stick to sound surgical principles. Choose flaps that allow for potential re-rotation or re-advancement if recurrence happens.
Plan for the future.
Yes, and do seat mapping after reconstruction, especially if an ostectomy was performed, as bony contours change. And finally, prevention and education are absolutely critical. They underpin everything.
That's a fantastic summary. This has been a really focused look at pressure sores, hitting those key areas relevant for surgical exams and practice.
Hopefully useful for revision.
Definitely. Understanding the etiology, the risk factors, how to classify them, prevent them, and manage them surgically and non-surgically is just fundamental.
It really is.
And maybe a final thought to leave our listeners with. Really consider how that deep understanding of pressure dynamics, tissue tolerance, building on concepts like Kosiak's principle, how that fundamentally shapes not just the immediate surgical plan, but the entire long-term care strategy to minimize recurrence after we've intervened.
That's a great point. It's about the whole journey, not just the operation. Thinking long-term is key.